Hello, I'm Dr Jodie Richardson, and you're listening to Well, Hello Anxiety, a podcast where we end the struggle with anxiety and build our toolkit of practical skills to thrive. Hello and welcome to another episode of the podcast. Before we get started today, I wanted to share a brief content warning just to let you know that today's topic might be a little bit tricky for some of you listening. We'll be talking about non-suicidal self-injury. So if you feel like you would be more comfortable skipping this episode and coming back to the next, then we wish you well for this week and we'll see you again next. Non-suicidal self-injury, or NSSI, is defined as deliberate damage to one's own body tissue without suicidal intent. And we know that NSSI starts young. Most start between the ages of 12 to 14. It's a difficult topic, but we are joined by a guest speaker today who I am so delighted to introduce you to. Joining me to shed light on NSSI is Madeline Wishart. Madeline and I met, and I'm so lucky to have met her a few years ago. We were both speaking at the ProPsych Mental Health in Schools conference, and I've followed her work closely since. Madeline is an incredibly experienced clinical psychologist with a special interest in this important topic. She specialises in non-suicidal self-injury and young people who experience difficulty in regulating their emotions and tolerating distress. She divides her time between private practice at Wishart Psychology and consulting with schools and organisations to really help shape policy and to support people within workplaces with their own professional development so that they can support themselves, each other, and the young people that they work with. So, Madeline, a huge welcome to you to the podcast.
Hi, Dr. Jodie. Thank you so much. I am actually really excited to be here on Hello Anxiety, speaking about non-suicidal self-injury with you.
Madeline, I would love just to get started because there's so much that I would love to know, and I know our listeners would love to know. And we're so thankful again to have you. You are such a kind, compassionate, dedicated professional and person and mum. And so I feel like we're in really safe, beautiful hands with you. So can you start by telling us more about it? What is it and what is it not?
I'll probably tell you a bit about how I got involved in this area, even initially, just to give you some context. When I was in undergrad psychology, was working as a residential care worker or, in out-of-home care, as it's sometimes called. And I came across a 15-year-old who had just self-injured. And as I was a relief worker, it was my first time in this particular residence, and I didn't even know where the first aid kit was in this particular house. I'd just come on shift. But what struck me more was just how incredibly distressed this young person had been and why they'd chosen to hurt themselves, and then how on earth could I help them? And it really got me curious. And that's what kind of started my journey in really wanting to help young people who were self-injuring. So then that's why I decided to do my PhD specifically in this area. So I think you summed it up really well at the start when you sort of talked about what self-injury is. It's an intentional behaviour, meaning that it's done on purpose. It's self-inflicted, so it's done to oneself. It's not socially sanctioned, so it's not what we'd call like a socially acceptable behaviour, like, for example, body piercing or tattooing, or even like excessive exercise and things like that. It's also, as you pointed out, undertaken without suicidal intent, which is an important differentiation, and it typically results in low lethality tissue damage.
Madeline, I appreciate already that insight just to help people get a better understanding of what it is that we're talking about with non-suicidal self-injury. I'm really interested to know just how prevalent it is.
Absolutely. There was a recent study in Australia, actually, the National Study of Mental Health and Wellbeing. They conducted the survey of health and wellbeing in 2020 to 2021, and they reported that 8.8% of Australians aged 16 to 85 years had self-harmed at some point in their lifetime. And so to give you some indication, that's comparable to the prevalence rates in Australia of panic disorder, obsessive compulsive disorder, generalized anxiety disorder, and agoraphobia. And what is also interesting is that these lifetime prevalence rates have remained pretty consistent in Australia over the past decade. There was another large study done in 2010, the Australian National Epidemiological Study of Self-Injury, or NSSI for short, and they randomly surveyed 12,006 Australians, and they reported a lifetime prevalence rate of 8.1%.
Right. So not a huge change.
Not a huge change in 13 years. So I think that's quite noteworthy.
Yes, I agree with you. And it's comforting. And I wonder whether or not, given the times that we've been through, the uncertainty and the challenge and the distress, especially, and I'd love to talk about prevalence rates in the younger age group as well, whether or not perhaps in time, do you anticipate, or is your experience that there seems to have been a change amongst young people given what we've been through with the lockdowns and the pandemic?
That's such a good question, Jodie. And it's interesting because there were lots of reports at the start of the pandemic, particularly during lockdown periods, that there were increased rates in self-injury. However, we're still actually looking at data. What we do know is Monash Hospital in Victoria actually released some data that showed that there was actually not an increase during lockdowns, which was quite fascinating. There's a number of reasons that we could hypothesize for this. Perhaps people were fearful of presenting to hospital during the pandemic for fear of contracting COVID. People might have been concerned about long waits in emergency departments, or people mightn't have wanted to put a strain on an already strained healthcare system. And perhaps people were seeking support in community-based mental health services or through private providers as well.
That makes a lot of sense. It's so interesting. There's so many moving parts when it comes to these things, aren't there?
Absolutely.
Yes.
It's kind of a bit of watch this space, really, isn't it?
Absolutely, it is. Is it more prevalent among children than adults?
It's quite interesting because the data that I quoted was kind of lifetime prevalence rates. But typically, the age of onset has been reported in the clinical literature from 5 years of age right up to 60. And so, for example, in my research, the age range was 2 to 56 years of age. And that's for the first time someone ever injured themselves, Jodie. So that's quite fascinating. But what we do know in both clinical and non-clinical populations is that this is behaviour. You're right. They typically does begin during the period of adolescence. And age of onset typically is between 12 and 16. And that's been consistent across time. We do know that earlier onset, so beginning self-injury at an earlier age, is typically associated with more severe manifestations over time.
Okay. Yeah. All right. Thank you. I'm still reeling from the fact that in your research that somebody of the age of 2 was a part of that data set. That's just... yeah, it's really tough. It's really tough.
It is really tough.
Yeah.
And I think an important note is, though, typically when we do have younger people, that young self-injuring, it's often associated with early childhood trauma or early onset of mental illness, or sometimes both. So that's a big flag for us, I think, to look out for as well, as to what is going on for that young person so we can better support their needs.
It's a very difficult concept to understand because the long-held belief, I think, the general understanding of NSSI is that the act of self-injury helps relieve psychological pain. But there is that infliction of physical pain. And so it's...
absolutely.
Yeah, tell us about why, please. What function does this behaviour serve?
That's such a good question, and I'm going to take it back a little bit even to what you said. It's such a confusing and perturbing behaviour to most of us from the outside looking in at it, because the fact that someone is creating a physical wound to heal or to cope or manage with emotional pain or distress seems just really confounding. And this is an important point, I think, is that young people who are engaging in this behaviour are that distressed and they are just trying to manage or cope with that. And something I like to do, and if you're up for this, I might even get you to do this with me now,
Yes,
Jody,
yes.
and ask the listeners to do this. Now, please don't do this if you're driving, because I'm going to ask you to close your eyes.
Great caveat.
Yeah, absolutely. And if you're not comfortable closing your eyes, just, pick a fixed point to look down to. And I want you to just take a few moments to think about how you cope. I want you to picture a slightly stressful day that you've recently experienced, but nothing too distressing. If any of you are familiar with the subjective units of distress scale, which is a tool to measure the intensity of distress, think about something at about a 40 out of 100. So it may have been that you were just juggling a bit too much. There was an incident at work with a colleague. You got cut off in traffic, frustration with a family member, something like that.
All of the above.
Yeah, check. Absolutely. So whatever it was, I want you to just think about what was your immediate go-to strategy for dealing with that stress? What popped into your head the minute you felt stressed? Because our coping strategies, they can be adaptive, functional, and productive, like seeking help, calling or texting a friend, trying to problem solve, engaging in some breathing or mindfulness-based exercises, or talking to a mental health professional.
Yes.
Yeah. Alternatively, our coping strategies can be unhelpful. They can be non-adaptive, non-productive, or emotion-focused, like blaming yourself, ignoring the problem. I often call it ostriching or turtling, where you retreat, hoping the problem will just go away. Doing that very toddler, la, 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 I can't hear you, worrying or drinking.
Yes.
So thinking back then to your go-to coping strategies, how many of you all listening today would say they were actually helpful coping strategies? And that's simply what non-suicidal self-injury is. It's simply an unhelpful coping strategy. It's a behaviour that's used to cope with any stress, overwhelming emotions, negative thoughts, uncomfortable physical sensations, unwanted images, memories, or urges. Now, Jody, many people would say to me, but Madeline, it is helpful. Lots of the young people I work with really challenge me in that and say, yes, it is helpful though. And I understand that it's maybe helpful in the immediate short term, but this isn't a behaviour that is helpful across time. It's got lots of consequences involved in this behaviour over time.
It's classic from acceptance and commitment therapy that the solution can become the problem.
Yes, absolutely. Yeah. And very quickly, because it can help in the short term, it can very quickly become a stable and consolidated coping mechanism, meaning that the young person uses this for any of those things that they can't cope with in their life, any distress, any discomfort, any uncomfortable feelings or emotions, and they use that consistently across time.
I love the way you've questioned all of us. And yes, so it was just really nice, I think, to have that opportunity just for us all to reflect on what do we do? Because most people listening will not be self-injuring, but that does not mean that we're using productive, helpful, healthy coping strategies for our own stress as well.
Absolutely. Like, how often do we say to a friend, oh, I just need to go home and have a glass of wine or a beer, or I need to go for a run. I need to sit down and binge watch something on Netflix and hoe into a tub of Ben and Jerry's,
Yes.
something like that. So it is really important to try and put this in context to understand that this is a behavior. It's a way of coping. And that can help as well to dispel some of the myths about this behaviour, which is something I'm really deeply passionate about, Jodie.
Yes, please, please tell us. What are the misconceptions that we can debunk here today?
Absolutely. Well, I suppose something that I hear the most, and Jodie, I'm sure you'll guess straight away, that I hear the most whenever I go into a school, I inevitably get someone put up their hand and go, yeah, but it's attention seeking, right? Now, there's so much stigma still associated with this behaviour based on this perception that it is an attention-seeking behaviour or a mechanism for manipulating others. And I really want to challenge that. Yeah. Why is trying to get someone's attention so bad?
Yes.
I don't get it. What does that say about us, I think, Jodie, as a society, that we judge and label a young person with this phrase when they are clearly crying out for help?
Yes. They're
Right?
crying out for help. Let's recognise it and help them.
Absolutely.
Yes.
The fact that a young person is actually choosing to injure their own body should be a big red flashing light, bells, whistles, warning signs that this is a young person that is clearly experiencing something that they just can't cope with.
Yeah, yeah.
They are expressing in non-verbal ways that they need help, which is incidentally why I called my research The Body as a Voice.
Yes.
It's their way of communicating their struggle. And so I actually would like to reclaim that phrase, attention seeking. But I feel a bit like Gretchen Wiener, from Mean Girls.
Yes.
And people are going to say, Madeline, stop trying to make fetch happen. Yeah? Stop. It's kind of a bit like that for me. So I go with a good old-fashioned CBT reframe and make it more palatable to people, I think, and call it like an attention-needing behaviour.
Yes.
Or there's a couple more I love, help-seeking, care-seeking. I love this one, connection seeking.
Yes.
Or help activation even.
Yes. Oh, I love all of those, particularly connection seeking.
Yeah, I think that's really powerful. And it just helps people reset the way they think about this and that young person's behaviour a little bit. I also want to flag that it's really important to note that the majority of young people who self-injure almost always do so in private. On parts of the body that are not visible to others.
Right.
They often go to great lengths to hide this behaviour, as we know, from family, from friends, and they rarely seek medical or psychological assistance for this behaviour. So I think that can really help dispel, I hope, this myth that it is an attention-seeking behaviour.
Yes. And it makes me think that if, when we're talking about non-suicidal self-injury, the most common way of injuring for young people is cutting. Is that correct?
That is correct.
Yes.
Yeah. Overwhelmingly so. And that's been consistently since the very first time this was reported in the psychiatric literature was by Emerson in a paper called The Case of Miss A in 1914, Jodie, in the very first issue of Psychoanalytic Review. And so cutting has across time been consistently the most common method. And, we think that is because cutting, breaks the tissue, activates endorphins. And so it creates this endogenous reward loop, basically, which is why this behaviour can very quickly become habitual.
Yes, because that's really releasing our body's own opioid, isn't it? That's
Absolutely,
right. Yes.
Absolutely. It's like tapping into the brain as a 24-hour pharmacy, basically.
Yes, yes. And so what there's so many questions that I've got, and I want to talk about the urges, and I want to also talk about what we can do as parents, or what parents get right, what parents could do differently, and always remembering, parents, if you're listening, that and always remembering that when we know better, we do better. We do the best we can with what we've got, and then that's why these conversations are so important. But before we go down that path, for parents who have a child who is self-injuring but keeping it very private, by the time they're teens, there's no walking on them in the shower or in the bubble bath or in their bedrooms. They're obviously, doors are shut and everyone's covered up. What can parents look for? What are some of the signs to look for that this might be happening, even though you can't see the evidence of it happening?
Obviously, there's unexplained scars or injuries that you can look out for. Dressings on parts of their body, like bandages or band-aids repeatedly. Wearing clothing also to cover up body parts. So, like, if it's warm, Jodie, and a young person's wearing multiple bangles on their arms, for example, or not wanting to engage in swimming or school sports because they don't want to get changed in front of other people, for example. Also, perhaps you might notice things that are a bit unusual around the home, bent paper clips or things like that you can look out for. There could be a collection of first aid materials that you discover that a young person has put together. Could be hints in their schoolwork as well. I recently had a staff member from a school tell me that NAPLAN had contacted their school to, send some alarm bells with regarding to what a student had written in their NAPLAN essay, which I was really impressed with. So things like that, yeah. There's also when a young person gives excuses that just seem kind of uncharacteristic for them, like, oh, the cat scratched me. And you're like, well, we don't have a cat. Things like that. Then there's also secrecy. So retreating to their room or to the bathroom a lot, because this is a behaviour that does create secrecy, physical and emotional distance. Also because not only from trying to hide the wound, but because of the guilt and the shame that are generated from engaging this behaviour and trying to keep it a secret. A final one I think to watch out for as parents too is if the young person starts washing their own clothes. As you know, Jodie, I've got two teenagers myself.
Yes.
Do they
13
wash?
and
16. They certainly do not wash their own clothes. And that might be a bit of a flag for me.
Yeah.
I do have lots of young people saying I hide it from mum because I just wash my own clothes.
Oh.
If I get any blood on my clothes or anything like that. Yeah.
Yes. Oh, goodness. So there are lots of things that we as parents can look out for in it. And I think that we know our children best. And so our gut instincts around our kids and their well-being, I think, are really important to listen to as well. You've given us those really tangible signs to look for. Madeline, I know that before you were talking about the release of endorphins with the cutting, and that there is this sense of relief or endorphins that are released because of the physical injury. Can you tell us what the function of this behaviour is for anyone who is self-injuring?
Sure, Jodie. And there's actually many different reasons. This is a really multi-determined, kind of multifaceted behaviour. People do it for so many different reasons. They are different for each person who self-injures, and they may even be different each time that one individual self-injures. They're often really contextually based too. The most commonly cited reasons or functions for non-suicidal self-injury are affect regulation, basically to change the way you're feeling.
Yeah.
Because you're feeling overwhelmed, distressed, intense, really huge feelings, and you just can't cope with them. Yeah. Or because you're feeling numb, empty, dissociated, depersonalized or derealized, and you want to feel something. There's also a self-punishment element. There's also an anti-suicide function to this behavior. Yeah. And this is a really important, I suppose, caveat as to why we don't have conversations with young people about just stopping this behavior without equipping them with other skills.
Yes.
Because it may very much be their way of interrupting, changing, or stopping suicidal thoughts and impulses. It's also a communicative behavior. Yeah, it's a way to communicate their unbearable or inexpressible distress, either to communicate that to themselves or to someone else. It's also creating a physical wound that's easier to care for than the psychological pain. And then there is kind of like a toughness and a sensation-seeking element that occurs only very rarely with this behavior. And then there's fitting in with peers or bonding with others. Again, those sort of interpersonal functions are not nearly as common as the intrapersonal or internal functions we see associated with this behavior. So, as you can see, lots of different reasons, and young people might engage in their self-injury at any given time for just one of these functions or many.
Yes.
All at once.
Where are we at with understanding how frequently and for how long people will self-injure?
And it's kind of like, as my old supervisor used to say to me, how long is a piece of string, Madeline?
Yeah.
Yeah, it's a very individual and personal sort of journey. And look, this is actually a good point, because this is something I do talk a lot about to parents of young people that I work with. Because often there's this expectation that treatment is going to be this lovely linear process. From A to B, it's a straight line. Madeline will start seeing this young person and the self-injury will stop at point X. And unfortunately, the trajectory is not that smooth. It's obviously a bit more like a roller coaster, realistically. And I think it's important to set up that expectation. This is a behaviour that doesn't have any quick fixes or magical cures. And it takes time, because we're essentially trying to extinguish one behaviour and replace it with other, more effective, helpful, long-term coping strategies. And I think it's important to set up that expectation as well, because we want to minimise the guilt and the shame that young people feel around this behaviour. And so we don't want them, when they have a lapse, to feel really guilty and feel like they can't talk to us about that, because that's going to absolutely maintain and perpetuate this behaviour.
Yes.
We want to talk to them about lapses and turn lapses into an opportunity for learning and growth. So saying something like, what did you learn from your lapse yesterday that you can put into practice next time you have the urge to self-injury?
Yes.
You know, I love those exception-based questions.
Yes, yes. And this idea that it is an urge. Can you talk to us more about that, please?
It's really important to provide young people with some psychoeducation about urges, because urges can be really overwhelming and scary when you're in the midst of them, yeah? But an urge is simply a craving or a desire to do something. We all experience urges, yeah? Urges to smoke, to gamble, to take drugs, to binge eat, eat that whole packet of Tim Tams instead of just one, to exercise sometimes. In this case, the craving or the urge is to self-injure. So the urges can be strong, powerful, and uncomfortable, but they don't last forever. They come and go. And I often talk to young people about urges as being like being bitten by a mosquito. Yeah, you straight away have that urge to just scratch that itch, right? You know from your past experience, though, that if you scratch that itch, it will actually itch more, because by scratching it, you stir up that mosquito saliva, which only increases the histamine response there. Then you may scratch the top off, making it weep. And if you keep scratching it, it may become infected or create a scar, much like self-injury. So I really like looking at urge surfing with young people. And this isn't something that I've created. Dr. Alan Malat, who was a specialist in addictions treatment, actually developed the mindfulness-based technique called urge surfing to get people to observe their urges. And then Dr. Kim Gratz, who's an amazing expert in non-suicidal self-injury, applied this technique to managing the urges of self-injury. And it's basically similar to exposure therapy in that the more a young person sits with their urges, observes and watches them over time without acting on them, the less intense the urges will become over time. And I often use another bit of a metaphor to describe this. Very much I practice those third wave perspectives of dialectical behaviour therapy and acceptance and commitment therapy, which are very rich in metaphor, aren't they, Jodie?
It's brilliant. It's so palatable that way. It's so easy to understand. Yes.
Well, it resonates with me personally, I think, so I'm very comfortable in that approach. But if you think about an urge like a child throwing a tantrum in a supermarket when mum refuses to buy a block of Cadbury chocolate, yeah, and the little kid's there with mum at the supermarket and they're at the checkout and they're like, Mum, I want a block of chocolate. And mum's like, no, we're going home to have dinner, honey. And then the little kid starts screaming, Mum, I want a block of chocolate. I really want a block of chocolate. Mum knows that if she gives in and gives, her child this block of chocolate, the next time they go to the supermarket, this child's going to up the ante straight away. Yeah. And be like, I want the block of chocolate. And that's just what urges are like. They're like that loud, screaming toddler. They're noisy, impatient and loud. But we know that, if we give in, the urges are going to become more frequent, just like the demands from that toddler.
It's the perfect metaphor for all of us. We can easily relate to that. And it makes so much sense. It's very easy to understand in theory, harder to do in practice.
Absolutely.
Isn't
very
it?
hard.
Yes.
Very hard to do in practice. Yeah. And that's why this is a behaviour. It does take time to shift.
Yes, it does. And you teach the young people that you work with, but also in your incredible work as a professional speaker in this space and, of course, an educator and a consultant. You're equipping adults to help the people that they work with, whether or not they're in a healthcare setting or whether or not they're in a school setting. And so what would be one example of a distress tolerance skill that you might share with a young person to help them to kind of ride that wave or surf that urge?
I use very much a lot of distress tolerance skills. I draw heavily on dialectical behaviour therapy for that. And this is such a good point because, look, lots of people try things with young people who self-injure and say, oh, I've tried that, it doesn't work. I've tried that, it doesn't work. And one of the big take-home messages I suppose I can offer for listeners here today is that it's really important that we match any alternatives that we're providing young people with to the function or the reason that they're self-injuring. So, for example, if a young person is feeling really numb, really dissociated or depersonalized or empty, we want to create some sense of bodily awareness or a physical sensation or use grounding or reorienting strategies to really get them to connect with that present moment. Things like the 5, 4, 3, 2, 1 strategy. I don't know if listeners are familiar with that, Jodie, from any of your other podcasts. I think one of the most important take-homes I can offer listeners today is that it's really important that we actually target any alternatives for this behaviour, any alternate coping strategies to the function or the reason that a young person is self-injuring. So, for example, if they are self-injuring because they're feeling numb, dissociated, empty, depersonalized, we want to try and connect them with the present more, connect them back in their body, use some grounding or reorienting strategies. One that I love is alpha lists. And I actually used this myself at the dentist recently and found it a really effective technique.
Yes.
So basically, for every letter of the alphabet, you have a theme. And so, for example, I often do fruit or vegetables.
Yes.
So A is for apple, B is for banana, C is for carrot, and go through like that.
Yeah.
You've really got to hold in your mind what letter you're up to and then find something for it. So it uses a lot of brain power to do that. Another one I really like for listeners is fizz buzz, counting to 50 or 100
Yes.
and replacing every 5 or multiple of 5 with the word fizz.
Yes.
And replacing every 7 or multiple of 7 with the word buzz. So, yeah, this one I really struggle with because I don't love math.
Yes.
So it's 1, 2, 3, 4 fizz, 6 buzz, 8, 9 fizz.
Oh, wow.
And so on.
Oh, that's great. I love
Yeah.
that. And I just wanted to add to the alphabet list that sometimes when I can't sleep at night, I will go through the alphabet and naming things that I'm grateful for.
Oh, I love that one.
I don't get far. I don't think I get past F before I'm sound asleep. But it just takes your mind. It just, like you say, it brings you back sort of into the present and bringing your thoughts away from what might be worrying you or causing anxiety or just something that's winding you up instead of winding you down.
And look, for those who struggle, I suppose, to do something that cognitive, something I've done in therapy sessions with someone who's been very distressed. And I recall a client who cried pretty much for an entire 90-minute session once, Jodie. I always have soft toys, or I have a lot of sensory things also that I draw on in my therapy space. And this particular client was holding a big soft toy lion I had. And so I just got her to describe, using all of her senses, the lion in detail to bring her back to the present moment and to ground her so she didn't leave that space feeling so dysregulated and so distressed.
Yes, so we can use what we have.
Absolutely.
We can use what we have, and each of these are available to us in the moment. Fizz bars, alpha lists, a soft toy. Most homes will have one of those. I have a giant teddy bear floating around somewhere that we need to get rid of. It's too special to just part ways with, but nobody really wants it anyway. But yeah, you're exactly right. Now those and what you said about matching the alternative to the function of the behavior, I think is really important. And further discussion around that is probably beyond what we can incorporate into this conversation, but might open the door for another conversation maybe down the line. I'm winking at Madeline. Okay.
I can spend a whole day, I think, just talking about that in particular. Yeah.
Yes.
And one other thing, I suppose, Jodie, is it's important to then also encourage young people to try different strategies, because we live in this world of instant gratification where we're used to paying attention to 30-second snippets of information or visual material. So it's about teaching young people to persevere, to persist, to have some patience. And if one alternate strategy doesn't try something else. If that doesn't try something else. And if that doesn't try, perhaps the strategies they're trying aren't meeting that particular function in that moment.
Yes.
So it is important to really convey that message of persistence, I think, to our young people.
And that it is, as you've already said, it is a journey. There is a path to travel. It's not a straight path, but wherever you are on the path, you're ahead of where you were. And I think that what you're sharing today is really helping anyone who's listening, whether or not they're seeking help for someone they care about, they are getting help, or they're not yet on that road to get some extra help. There's support no matter where anyone is at on that journey that you've shared with us today. And before we finish, I'd just love for you to share for parents listening who incredibly painful position to find oneself in as a parent, that this is happening with one of your children. What can parents do to make a difference? Or another way maybe to put it, perhaps another part to that question is, what can parents do that's not as helpful as parents might think it is?
And that's a good question too, because it's often just as important as what not to do as what to do, isn't it, Jodie?
Yes, yes.
Definitely. One of the things I suppose that we want to do is we really want to actually reinforce the young person for disclosing to us. So whether this
Yeah,
is your child or if you're working with a young person in a school in any different capacity, as a teacher, as a well-being person, as a mental health practitioner, it's really important that we actually thank them. It's
yeah,
such a privilege. This is something that I really, really am very grateful and appreciative of. Having a young person trust you with their experiences, their innermost thoughts and feelings, it is a great privilege.
yes.
And it's really important that we recognize and celebrate that, because it also then reinforces future help seeking. And I think so we really also want to talk openly and honestly about this behaviour. We want to minimise any guilt and shame around this. As we've talked about, that just perpetuates and maintains this behaviour. We want to really remain calm and avoid emotional extremes.
Mm.
And I'm a parent. I get how hard that is in reality.
Yes,
You know, our kids are really great at pushing all our buttons. Yeah.
that's
However,
right.
this is a behaviour that's typically associated with emotional dysregulation. So
Yes,
we want to role model appropriate displays of emotion and regulating emotions. And we want to actually also role play having a whole range of emotions. We just want to watch our intensity and the appropriateness of how we actually express our emotions. We also really want to encourage that talking about emotions with our young people as well. I think that's really, really important. We want to be there. We want to offer invitations to talk,
yeah,
but not pressing them, not
yes.
cornering them and forcing a Spanish Inquisition on our on our kids,
Yes,
basically. Yeah.
yes,
I think that's important. And we also want to celebrate successes. We want to, remember it's that old carrot, not the stick metaphor. Catch them being
yes,
good.
yeah,
Yeah, I think this is really important. When we see them expressing their emotions in really healthy, appropriate ways, congratulate them, reinforce them, reward them in some way for that. We want to also watch out for signs that they're experiencing intense emotions and then help to distract them by comforting them or recommending alternatives as well. We also want to be mindful of what their social media usage is like as well, because young people often will then just invest huge amounts of time looking up things related to self-injury or following people's mental health blogs and so on that might not necessarily really be very supportive in helping them to decrease this behaviour. And it also detracts from their time engaging in real life relationships, face to face connections, with other young people, which is so important as well.
it really is. You have shared so much. We've covered a lot in this time that we've had together that I think is a really beautiful, more than a foundation for our listeners today and for anybody who works with young people or anybody who is injuring themselves. I think that our conversation today is just so important and is hopefully going to be a launching pad for a lot of people to be able to seek help, to be able to better support the people in their family or in their classroom or in their workplace, and also to just have that compassionate understanding of where it's coming from. You've really broken down some of the misconceptions about why it happens and helped us to understand that there are a whole variety of reasons why it does. And also, of course, what our role is as people caring for someone who might be engaging in this behavior. And even the fact that you call it a behavior, I think gives hope to anyone who's in the midst of this kind of storm in their own family that behaviors can change if this has brought up challenges for you and that you are feeling like this is a bit much for you to manage on your own, or you've recognized something that's happening that you weren't fully aware of before listening to this episode, please reach out to speak to your therapist, your counsellor, or to your GP to have that conversation to get the support you need so that you can be the support for the people around you that need it as well. So, Madeline, thank you so much for your time. Honestly, this is going to be the first of more conversations on the podcast, if you're willing.
I would be absolutely okay with that. Yeah,
Great. Okay, great. So how can people learn more about you and your wonderful work?
Oh, Jodie, thank you so much. Look, you can actually go onto my website, madelinewishart.com. And I've got lots of resources there. I've got resources for parents, for young people, for practitioners, and for schools that you can access, lots of different links to see. You can also find me newly on Instagram, Dr Madeline Wishart.
Give her a follow.
Thanks, Jodie.
Yeah.
And I suppose I would also like to end with highlighting that this is a really distressing behaviour to cope with when you have a young person in your life that is self-injuring. And so it's really important to practice self-care here. And there's this Zulu proverb that I really love, and it's that you cannot wipe the tears off another's face without getting your own hands wet.
Oh,
isn't it beautiful?
Oh, it's beautiful.
And, it's just that remembering to apply your own oxygen mask first to best help support others.
I never understood that as a kid on a plane. I would hear that oxygen mask safety instruction and think, what are you talking about? And now it rings true in every aspect of our lives as adults, doesn't it? We cannot care for others if we're not caring for ourselves. And of course, these distressing circumstances are difficult to cope with. And so I'm really pleased that you're able to finish by sharing that beautiful proverb and that beautiful recommendation. So thank you again, Madeline, for sharing your time with us today.
Thank you so much for having me. It's been great. I really appreciate it.
You are so welcome. And thank you for listening. Thank you for joining us. Please consider sharing this episode with your school community through the wellbeing coordinator or through the school counsellor. Please also think about anyone else who might benefit from listening in to my conversation with the wonderful Dr. Madeline Wishart today here on the podcast. Thank you again for your time, and I'll look forward to being back with you for another episode again next week. Okay, bye. Thank you so much for joining me for this week's episode. If you enjoyed it, please subscribe and leave a review. To keep the conversation going, I'd love you to join me over on Instagram. You'll find me at Dr. Jodie Richardson. Also, if you'd like a copy of my free 5-day mini email course, Calm Your Anxious Brain, then jump over to my website, drjodirichardson.com, and you can sign up down the bottom. I've really enjoyed having your company. Thanks so much. See you next time.